Follow the conversation. This is Afternoon on the Dove.
Good afternoon. Welcome to Afternoons on the Dove. I'm your host, Perry Atkinson, and we have a pretty interesting program put together for you today. You know, we do a lot of shows about living well and eating well and doing all the right things with our diet and food and things like that. How about the subject dying well? Well, that's what we want to talk about today, and our special guest is Dr. Barry Hamman. Dr. Hamman was born in San Diego, California, graduated from college in Santa Barbara with a bachelor's degree in biology. Dr. Hamman attended Loma Linda Medical School and interned at Kaiser Permanente in Fontana, California. He completed his family practice residency in Ventura County Medical Center, which is affiliated with UCLA in Southern California. And what a delight to have Dr. Hamman with us today.
Thanks so much for having me.
Yeah, this is an interesting topic. We do a lot of shows, as I told you, about living well and good habits of eating and living and medical practice, but we've never dealt with the subject of dying well. And yet the essence of what we claim here on a Christian radio station is there's a better life on the other side for us, for those of us who believe in the Lord. But what do you mean by dying well?
Well, it's my contention that we have learned, we've lost the art of dying well in the United States in particular. I've spent some time in other countries and have had some experience of seeing how people die in other cultures. And I think what I would say to sum it up would be that we have over-medicalized the end of life. And by doing that, we rob ourselves of dying well. So what's dying well? Dying well is dying at home, preferably, if that's at all possible. Dying with those that love you around you. It's making sure that all the loose ends have been taken care of, particularly when we talk about a Christian perspective of dying well. Don't be going out with unresolved conflict. I see a lot of my patients coming in still trying to please their dead family members as a result of their family members not dying well, not resolving the conflicts that they had when they were able. Dying well, I think, also includes dying in such a way that there is an emphasis on the comfort aspect of it. Very often what I see now, and in fact what was just showing those statistics pretty disturbing, about 80% of people that die today die in an institution. And when we die in an institution, it's much more difficult to die well. It's not impossible. I've seen some people die well in an institution, but the best deaths are the ones in which a person is fully in control, aware of what's going on, and able to express love and receive love from those around them. I know that from the hospice workers, for instance, being present during a good death, if you will, is a very powerful experience. It's something that you never forget. And we have, in our culture, largely robbed people of both dying well as being present for a good death, if you would say.
You mentioned at the beginning of your explanation there about being perhaps over-medicated, and I want to get into that part of it, but it's so interesting to me that we Christians talk about heaven, but we're really not too anxious to get there. And at the end of the day, we really don't like talking about dying. Why?
Yeah, I don't know what the answer to that is. My concern is, and I think that the evidence is leaning in that direction, is that we think we are obligated to hold out hope until the very end, like God will somehow, if we have enough faith, will heal us from our terminal condition. And so to be a good Christian, we need to ignore the inevitability of death and to forge ahead with faith, because that's what God is asking us to do. And I think that's a misnomer. I think that God does not expect us to expect Him to pull in and make us live forever on this earth. I think that God is honored when we accept the inevitability of death and we die well.
Now, I want to get into the aspect of maybe, as you mentioned, excuse me, being somewhat over-medicated. What do you mean by that?
I'm using the word medicalized and not just medicated.
Okay.
I don't have any trouble at all with somebody who is in pain receiving morphine, even to the point perhaps where the person is no longer able to be conscious or alert or awake. So that's not a good term. We often use morphine in a setting like in hospice. If a person is in absolute agony, it's my feeling that they don't have an obligation to remain conscious somehow and to live as long as possible by withholding pain medication. So when I say the word over-medicalized, I'm referring primarily to those actions that are taken with the idea of prolonging life. So, for instance, let's say you get diagnosed with a terminal illness like a cancer, and then you you go on chemotherapy or something like that, and then you have a complication of the chemotherapy. And as life progresses on here, the chances of the chemotherapy helping you are diminished, but you still choose those. You still continue because that's kind of what people do when they have cancer.
Right.
And then in the end, you end up dying in the hospital, sometimes of a complication of treatment that really was almost to the point of being ridiculous that you were choosing that treatment.
Who makes that decision? I mean, you're the physician. I mean, you obviously are approaching this differently, but don't physicians just say, this is what you do, go for it?
Well, I think that's also part of the problem. I think we physicians tend to approach a problem, we tend to approach a disease state with a solution for a disease. And I think the Christian approach ought to be approaching the entire person. And when you are disease-based, you tend to reach for those treatments which will cure the disease, sometimes at the expense of the personhood, if you will, of the person that is there. Am I clear on
Yeah,
on what
I
I'm
think you
saying
do. I think you're saying some things that are so obvious that I don't know why we don't practice this when it gets to that time, but go ahead.
Well, even yesterday I had a patient come in. She was new to me, had been taken care of by another person, another provider, and she has non-small cell carcinoma of the lung, and she's been through some chemotherapy. And as I began to talk to her, I realized that she was likely has a terminal disease. She's already 2.5 years into this. And when I began to talk to her about the importance of making some plans about what she wanted the end of her life to look like, she had not yet had that conversation with any of her providers over the last 2.5 years of treatment for terminal disease.
Whoa.
That should not happen. Now, she was not willing or ready to have that conversation with me, but each time that she comes in to visit me, we will again broach that subject. And a part of it is her fear, and we need to get beyond the fear of dying. Part of it is, sometimes it's actually a selfish thing on the part of a person where they don't want to have to think about it, and then they end up leaving a mess for other people to have to try to figure out when they no longer can make decisions for themselves.
Let's talk about the decision process for a moment before we get into some other aspects of this, and that is we have these things, these documents called a medical directive. And I don't know why we just don't automatically sit down and do that. Maybe it's because it's forcing us to deal with the inevitable, but I'm surprised how many people get to the end of their life and they got nothing in place. Nothing in place.
I think that Oregon actually has been ahead of the game on this. We have what's called the PULSed form. A lot of people refer to it as the pink form. And the pink form is, and PULSE stands for, it's basically physician's orders for end-of-life care. And on that form, we address whether or not you would want to have a tube placed inside of you and go on a respirator in order to save your life. If you wanted to have a tube put in to have artificial nutrition given to you, whether or not we would use antibiotics, some of the basic questions that we have to answer when we're trying to decide how to care for somebody as they're approaching the end of their life. I think these forms are very useful, and we now have a state registry, and it's listed on the form. Any providers ought to have access to that form, and you can go on the Oregon site as well, on the PULSed POLST, or state of Oregon, and you can pull one up and kind of look at that. If you put it on the registry, then if someone calls the ambulance, they come out to your house, and you've filled out that you don't want to be intubated, is the term that we use in putting somebody on a respirator, they can look it up. The ambulance driver can look it up and say, oh, well, this person clearly didn't want to have this done, and so we don't need to do this. So I think that's it. We ought to be doing it more often, and we don't do it because death is not a pleasant subject to talk about for most people.
All right. Now, as a Christian physician, let me just give some hypotheticals. As a Christian physician dealing with a Christian patient who wants all of these end-of-life measures, at what point do you say, hey, wait a minute, maybe God doesn't want you prolonged? I mean, maybe God wants you to die naturally. Does that ever come up with you?
Yeah, I mean, I very often, death has a way of making people spiritual, let's put it that way, and facing death. Yeah. So conversations about what is ultimately important is the kind of conversation as a Christian physician that I feel that I should have with all of my patients, whether they identify themselves as Christian or not. We have to talk about what's really important, and that at the end of life, what's important really is what is spiritual. And so then I most often appeal to rational thinking when I get to this place where I want them to make choices having all of the information. Sometimes people come into me and they'll be diagnosed with cancer and they'll say, well, I don't want to do anything. Well, I don't think that that's the right approach either, because generally speaking, cancer isn't just all the same. There's different types of treatments for different kinds and different stages of cancer. And so it's important that a person, as they begin to make decisions about the end of life, is that they have all of the information. So what I tend to find myself doing is coaching my patients for when they go to see the specialist, be it a surgeon or oncologist or radiation oncologist. These are the questions that you need to make sure you have answers to before you walk out of that office. And if you don't have those answers, you haven't done your job. Because it's easy to get on the freight train of doing what normally gets done when you have X diagnosis. And usually that's some kind of treatment. But you need to keep the no treatment option up there. But you need to have all the information to know what that is. So I encourage them to always be in control of their decisions. Make sure that too much information doesn't exist. Getting enough information to make an intelligent decision is what you need. So let's just take the example of cancer. If you go and you see the oncologist and they now have all the staging done, so they know what type of cancer, we have a pathology report so we know what we're dealing with. There are statistics available on all these types of cancers that give you some idea what the average lifespan would be after you have that diagnosis. You need to know those numbers. Right. Okay. They're often not told to the patient because it can come across as kind of a curse. You have 29 days left to live. You know? Right. But you need to not look at those things as inevitable, like you can start counting down the number of days that you live, but it gives you some perspective of how serious your illness is. Then the next question is, what treatment is available, if any? And the next treatment is, what can I expect from the treatment in terms of side effects? So you have some gauging of whether or not this is going to affect your lifestyle.
So quality of life and comfort is obviously huge in this.
So I love hospice's approach. Palliative care, hospice, it's no longer about prolonging life as long as possible, but doing what life you have left as well as you possibly can. So that includes quality of life. That includes what kinds of side effects you may be getting from the treatment. Now, we can't always, again, predict what those side effects may be for a given individual, but again, with statistics, you can get some sense of whether or not you're going to have a problem. And then you can make an intelligent choice as to whether or not you want to do that. And patients ought to always be empowered to be in the position of making the decision about whether or not they're going to go with treatment. I feel that they should never be coerced into going in or feel obligated some way that they're going to disappoint somebody if they don't go forward with a treatment that doesn't, for them, make sense in maintaining a quality of life as they approach the end of their lives.
All right, let me take a quick break. We'll be right back. And Dr. Bruce Hamman is with us today. We're talking about the subject of dying well. Maybe you have some questions or comments. You're welcome to join us, 776-5368. We'll be right back.
Follow the conversation. This is Afternoon on the Dove. Follow the conversation. This is Afternoon on the Dove.
We're back today, and our very special guest today is Dr. Barry Hamman. He's a doctor in practice there in Grants Pass and has been for over 19 years. We're dealing with the subject of dying well, and of course this is a sensitive topic to say the least, and if you'd like to join the conversation or have any questions about it, you're welcome to join us at 776-5368. And so often dealing with terminally ill patients, I guess you are strapped with the responsibility of being totally honest and transparent with the patient and giving them their options when it comes to this. And I don't know at what point do you move over and say, get your affairs in order?
I think that I like to start that conversation early, and even when I may be wrong about the terminal nature of their disease. Having this conversation is one of the most important kinds of conversations that we can have. If a person survives, for instance, cancer, are they worse off for having had that conversation or better off? And I would argue they're always better off to have been prepared. There was an author who wrote a book about cancer, and she was a cancer survivor, and I think the way that she put it was very good. And one of the things that she said is that many people have not lived until they have been diagnosed with a terminal disease. Well, folks, we all have a terminal disease.
Yeah.
And if we could rearrange the way in which we live our lives with that thought in mind, I think we may all be shifting our priorities a bit from what we would normally tend to.
Let me dig a little deeper in this with you, Dr. Hamman. And what about children that have been terminally diagnosed and dealing with the likelihood of dying, and the parents' role, and how do you tell the children? And I mean, what do you do with something as sensitive as that?
Be honest with you, I have very minimal experience. I've had very few patients that were younger in my care die. So I really don't know that subject well enough to know how to answer
that's
it.
a fair statement. All I know is that we've been involved with certain organizations like Sparrow Clubs that help terminally ill children, and boy, those are just tough moments to deal with. And so what about the family's responsibility on somebody that is terminally ill but just won't deal with it? How does the family come into play in maybe helping them?
Death has a way of bringing out the best as well as the worst in family dynamics. Very often what we find is that when a patient is terminally ill and perhaps no longer able to speak for themselves, you'll find an individual who was previously estranged in some way with the person who is dying, and they come in as a champion at the last minute to try to prolong the life of their loved one. And it becomes very difficult to speak common sense into the subject when you have that kind of, put it, messiness. It's also disturbing to me to be a part of a situation where a person is making a conscious choice to not die well and making everyone miserable around them in the process. And that's partly what brought me to the point of talking about this. An example of this is I had a lady who died here within the last year, and she was an elderly lady in her 80s, and she had some congestive heart failure, and she was getting down towards the end of life. She was living independently, but she made life miserable for everybody every day that came into contact with her. She refused to wear a lifeline, for instance, which is one of the companies here locally that you can push a button and call for help if you were to fall down. And when I asked her to do that, I said, I don't want you to wear this for yourself. I understand that you feel like this is taking away some of your autonomy or something, and I want you to wear this for your daughter so that she can sleep at night knowing that you aren't laying on the floor with a broken hip. She clenched her fists and she said, I will not wear one of those devices.
Wow.
This is an example of a person not dying well and, in fact, consciously choosing to make everyone miserable and them to be the center of all attention. We don't have to choose to die that way. She could have very easily put this little thing around her neck, and her daughter would have had a lot a lot more nights of good sleep, not wondering if her mother was somehow incapacitated or actively dying alone in her home.
Wow, that is a incredible story. I want to come back to managing pain and someone that's terminally ill and dying. You made the comment earlier that even to the point of unconsciousness, you felt was an okay thing to do.
Yeah, again, I think this gets at, in part, the Christian uncomfortableness that we have with death, and I think that we also tend to have a sense of an obligation to artificially even prolong the life, that somehow that is more dignified way of dying, and I don't believe that God asks us to artificially prolong our lives. And when you take that in light and you're asking about what about pain management at the end of life, in the same way, I don't think God asks us to go out in agony because somehow it may add a few more minutes or hours to our lives if we don't take the morphine. Most often what I'll find when a person is nearing the end of death and they're using morphine is they will choose consciousness and ability to interact with those that they love around them and pain over unconsciousness or confusion that comes with taking too much pain medicine. But there's some conditions which really are very, very painful at the end of life. An example might be, say, gastric cancer, where the stomach is now spilling acid into the abdomen. When you get to the point where it's that advanced, you are in absolute agony. And I've been in situations where we increase the medication until the pain is gone. And if death occurs as a result of treating the pain, I'm okay with that as a Christian physician. I'm not okay with flipping it around and saying, well, we're going to kill the patient, where the intent is to kill the patient, not to relieve them of their pain.
Wow.
Those kinds of circumstances are quite rare, where you have a person who's in so much agony and they're not able to get that under control with medication, and you end up titrating the medication until the point that they're no longer breathing. That's a rare occurrence.
Have you suggested a patient to maybe leave the facility and go home, knowing that it's within a matter of just a time that they're going to die?
Most often we are trying to figure out some way, let's say a person ends up in the hospital with a terminal condition. We're trying to figure out a way that would be possible, given the resources that they have and taking into account the diagnosis they have, and the people that can step up to the plate and help them to get them home if at all possible. But it's not possible in many situations. It's more than a full-time job for somebody to be cared for when they're dying. And that's, I guess, another thing that I would address is that we should not feel guilty as family members if it gets to the place where we simply cannot provide what needs to be provided as a person gets towards the end of life. That's not a failure when we seek help outside of what we can perhaps provide personally.
I'm aware, or amazed at so many times how aware some patients are when they're dying. People will talk quietly around them or whisper away. I mean, they're totally cognitive of what's going on and aware of what's going on. I mean, I'm thinking of the passing of my own parents and that experience, and I thought, well, my mother was alert up to up to about an hour before she passed, and I thought, there was no need to tiptoe around and be quiet. I mean, you ever seen that to be the case? Why do we go so silent during these times?
I don't know what that's about. I'm thinking of a participation that I was present at the death of a good family friend. I should say not at the actual death, but within a few hours of when she died. And she was in a long-term care facility because she was at the point where she was blind and needed care. And she was on a Thursday. She was very alert. She said, "Well, it's about time for me to go, and so we need to have my son come out from Michigan, and we need to gather the family around, and I need to say my goodbyes."
Wow.
And I was just thinking, wow, I mean, if you could choose a good death, this is the kind of death that you would want. So she did. She called the family members, and she said, "I can feel my body shutting down, and I know that I don't have much longer to go."
Wow.
And so I went and visited her. My wife and I went, and we chatted, we laughed, we told stories. She was alert. She was cognizant of what was going on. And her son arrived, and she said her goodbyes, and that evening she died.
Wow.
This was a very spiritual person and a mentor for my wife and I. And when I see somebody go out bravely like that, knowing and conscious of what was happening to her and her body and doing it well, it was powerful.
Wow. How much is the psychic a part of this? You kind of alluded to the fact she understood it. She processed it through her mind as well as her heart, but she processed it through her mind. This is it. And she had the cognitive ability to pull in family members. How much does the psychic play into this?
I'm not sure what you mean by the word psychic.
Well, I guess, I mean, you know, your ability to pull things together and come to a reality of where you are. You know, I guess maybe it's more of a psychological question because sometimes denial kicks in. You're not dying. You're going to beat this thing, you know.
Yeah. I guess the way I tend to see, you know, as I think about people, I think of them as body, mind, and spirit. And sometimes people are very conscious and aware of what is happening to them, and they can express that and have come to terms or peace with that. But other times people, you know, for instance, Alzheimer's disease or dementia is a very common cause of death these days, and those folks have no idea what's going on at the time they die. There's often years that lapse between when they were conscious and when, and even recognizing family members when they actually die or succumb to the disease. So it's actually kind of an exception, I think, when a person is awake and alert, conscious, and has also come to terms and are at peace with dying. The stages of dying are, you alluded to that, you know, sometimes people are fighting or they're in denial, and it's very common to see those things, and particularly when a death happens quickly from the time of diagnosis, we often don't have the time to process. And I don't blame people for their emotions at the time of their dying. I think we need to realize that emotions just happen. And sometimes they get directed at people around them, and we need to understand that as caretakers of people when they are dying.
Let me take one more break. We'll be right back. Dr. Barry Hammond's with us today from Grants Pass, and we're talking about the subject of dying well. I realize it's a sensitive topic, to say the least, and if you have any questions or comments, you're welcome to join us, 776-5368. We'll take a quick break, and we'll be right back.
Follow the conversation. This is Afternoon on the Dove. Follow the conversation. This is Afternoon on the Dove.
Well, good afternoon, and we're back with Dr. Barry Hammond today. He's our special guest from Grants Pass. We're dealing with the subject of dying well, which is an interesting topic, to say the least, Dr. Hammond. And thanks for coming in and being a part of this and helping us get a better handle on this whole process. And you named earlier the stages that people go through in dying, from maybe denial to anger to acceptance. But as a Christian, we believe that we're going to a better place. At what point does a person's faith come into the reality of what's happening here? As a physician, where do you lead them in that?
Well, it's obviously individual for the person who is reaching the end of their lives. But again, I like to broach this subject early on and make sure that they're conscious of that. One story that comes to mind is a lady that she was in her 50s, didn't have any family that lived locally, and she'd come into the hospital because she was having trouble breathing, and she was dying of lung cancer. And by this time, she's on like 100% oxygen, wearing a mask. And so when I came in, I said, "Wow, it looks like we're getting near the end here. We've done what we can, and are you ready?" And she was quite awake and alert and answering questions, and she didn't really have anything to say. And she was a believer. And I challenged her. I said, "I'm going to come back in tomorrow, and when I come in tomorrow, I want you to tell me if there's any unfinished business, either with others or with God, that you want to tell me about." And so she survived the night, came in the next morning, and I said to her, "So is there something that you thought of overnight about, unfinished business, making sure that everything is ready, that you've made peace with God and with fellow man?" And she pulls her oxygen mask off, and she says to me, "I want to hire a jet." And I was like, "Oh, lovely. Now we're gone. The oxygen levels dropped too low here, and she's off in some other land." And I said, "Excuse me, what did you say?" And she says, "I want to hire a jet." I said, "Well, tell me about that." And of course, she's kind of gasping between breaths and putting her oxygen on and off. And she says, "I haven't seen my parents, and they're too old and elderly to be able to come and spend time with me. And I want to go and spend the last days of my life with my parents." And they lived out of state.
Wow.
So I went to the discharge planner, and I said, "I got a patient here that'd like to hire a jet." And you can imagine the response that I got from that. And they're there, what, And this is what she decided that she wanted to do, and dying well, if you will, is she wanted to be with family. And she wanted to see mom and dad. And they were like in Mississippi or something. So she had some savings. She didn't have any relatives that would otherwise be getting an inheritance.
Yeah.
And so she spent I think it was $15,000 to fly to be with mom and dad for the last 2 weeks of her life. She died about 2 weeks later. So again, it's a story where when you start emphasizing what's important at the end of life, which is really relationships and spending time with people, dying well is much more possible.
Wow, what a story. Do you have scriptures that you share? Or you lean on to give people as comfort?
I would tailor that to the individual and perhaps what they are struggling with. Yeah, I do sometimes.
You do that. And, it seems to me that having family around, what I'm hearing you say is, maybe I'll just try to summarize this. If you can, be at home and have family around you and go for comfort, then perhaps
duration.
Duration, yeah. Is that what I'm hearing you say?
Those are, I think, some key elements. And again, it's very important that people don't somehow line those up and say this is the way it's got to be or it's not being done right. It does have to be tailored to each individual. Sometimes it's just simply not possible to do some of those things. This lady made it possible, by hiring a jet, which was an unusual kind of a story to be able to relay to you.
Wow. The other aspect is, can someone die peacefully with no family around them?
I think so. I think very often people die peacefully with friends. They stand in for family. And sometimes it's even nurses or caregivers that have a touch. People who are working in hospice very often are very helpful in that, but hospice does usually require that there be someone else involved to help with the day-to-day caring of a person. But we sometimes will use hospice services in a nursing home when there's not that available at home, and so then it kicks into people who are more accustomed to this approach to death, where it's about comfort and rather than about duration of life.
Wow.
I want to add to that, though, and maybe we already said this earlier, that there's a number of studies that show that people who choose to go the palliative or hospice route actually live longer statistically than those who choose traditional medical therapy. And to me, that gives hope. So when I'm counseling somebody to choose to go the route of hospice or palliative care, they need to understand that that's not throwing in the towel and saying the game's up.
Yeah.
It actually may help them live longer.
I have immense regard and respect for hospice. I have seen their services on so many occasions, and it's just been wonderful. Just been wonderful. I want to come back to cancer just for a moment. It seems to be a word that just sends the chill of death through everybody. and the moment these other things are prescribed, whether it's chemotherapy or radiation, whatever, people do come through it. I don't know at what point, as a physician, I guess there's various stages of cancer. I'm no physician, so I don't know. Is it stage 4 is the one that you're pretty much terminal and that's it?
Each type of cancer has different staging forms, and sometimes so it's very difficult to make a statement about it. It's really not one disease; it's many diseases. So I really can't address what stage a given cancer would be. Is that the number one killer? I mean, is that what you're dealing with most? It seems like to me cancer is almost epidemic. No, it actually is not. Number one cause of death in the United States is heart disease. Probably number 2 would be stroke. And 3, you're probably looking at, you're getting down into COPD, emphysema, that kind of thing. If you put cancers all together, it's certainly in the top 5. Yeah.
Wow. What do you say to people who are just beginning this stage that it is terminal, and you've gotten maybe through the panic stage and the anger stage? What's the next stage that happens? Is it a processing stage or a reality stage?
Look at the stages. The famous person that wrote about this to begin with is Kubler-Ross. So you may have heard the Kubler-Ross stages, and we're referring to some of those. And they tended to look at them as being something you went through sequentially, or often they're taught that way. But in reality, they can happen out of order. And sometimes people skip stages. So there's no one rule where you could say, well, this happens, and then when you're done with that, well, then this will start happening. So you kind of have to see what comes in, when you're the caregiver or a family member, and expect people to be in denial, expect for them to react sometimes in anger or disbelief.
What do you do with people that just give up? They don't want anything, they don't want to do anything, they just shut down.
Generally, they don't do well. Generally, if a person has given up and they're not going to do anything, there's an active form of that, which I often very much appreciate, where a person is actively choosing that I'm not going to go through XYZ treatment. I want to try to, just eat right and spend time with my family. I very much honor and appreciate that approach. But when it's somebody that says, well, I guess I'm going to die, and, I'm not going to do anything about it, that's not dying well. That's just throwing in the towel, giving up, not doing the things that they ought to be doing as they approach the end of their lives.
At what point as a physician do you help people to maybe get to reconciling some family dynamics, knowing that the end is near and making sure that they make peace?
Generally speaking, I challenge them to make peace. In terms of actually being there at the time that that's done, that usually is not very. It's not often something that can be done in a half-an-hour office visit with family members, but it often conflict will come out as family members come in.
Do you ask the question? Are you at peace with everybody in your life?
Yeah.
You do.
Yeah.
You get a straight answer? I mean, that's a pretty personal, deep question, isn't it?
Well, and if they choose not to answer that or say, I'm not comfortable talking to you about that, that's fine with me.
Okay.
But I think it is an obligation of mine as a Christian physician to talk about what's ultimately important with them and what could be more important than being at peace with people in your family.
Wow.
And often I would even go this far and challenge an individual if they were to say, no, I'm not. I have a grudge against so-and-so, or, there's some unresolved something. I would challenge them and say, your immune system doesn't work as well when you have unresolved conflict. And so your chances are not as good of pulling through this unless you address those deeper spiritual issues.
And I would imagine with your experiences through the years in medicine, you see somebody that is uptight and you kind of sense that they've got some unresolved issues.
Often, yeah, you can detect when a person is hanging on to something.
Have you ever had the opportunity to lead someone to Christ before they die?
terms of talking to them, I guess, you know, when we say it in that way, we typically think more of the 4 spiritual laws. And, you know, you say this prayer and then you're a Christian. If you were to define it in that way, I would say probably not. But if you were to ask the question, did somebody, as a result of me talking to them, come to know the God of the universe, Jesus, I would say yes.
That's wonderful. Will you come back? I'd like to go to the other side of this ledger and talk about healthy living.
I'm interested in talking about that. Obviously, that's the bright side of the subject that we have today, and I'm passionate about it. I think there's a lot that we can do in the way that we do life, and in particular as Christians, being an example and transforming our culture into one that embraces healthy living.
That's wonderful. Thanks for coming in, Dr. Hammond. I look forward to getting you back talking about healthy living and the aspects of doing that. I think there's many that can gain. We live in this pressure society. People are under the pressure today, so how do we help them to live better and enjoy life and do what God called them to do? So thanks for being with us today. Okay, and stick around. Tomorrow's Friday, and the Timidator will be in the house. We look forward to having him in and taking your questions. Have a good day.